Here's your high-yield emergency guide for COPD exacerbation, rewritten in a clear, structured, and so it's easy to grasp for USMLE PLAB prep. Management of COPD exacerbation. High-yield ting notes. 1. Initial oxygen therapy. Why controlled O2? COPD patients may rely partly on hypoxic drive for breathing, excessive O2, respiratory drive, CO2 retention, respiratory acidosis. Start 24 to 28% O2 via Venturi mask, target O2 SAT 88 to 92%. 2. First-line medical management. If patient is dyspneic after starting controlled oxygen, 1. Nebulized bronchodilators, salbutamol plus ipratropium bromide, often mixed in same nebulizer. 2. Systemic corticosteroids, oral prednisolone 30 mg ODs 5 days. If oral not possible, IV hydrocortisone 100 mg stat. 3. Role of IV aminophylline. Not routine. Limited benefit, high side effect risk. Only consider in severe unresponsive cases under senior supervision. 4. Antibiotic indications. Only give if sputum purulence increases, especially with dyspnea or sputum volume, fever and CRP rise alone indication. 5. Escalation to non-invasive ventilation, NIV. When to start? After oxygen, bronchodilators, steroids, and antibiotics, if needed, have been given. And ABG shows respiratory acidosis. pH 7.25 to 7.35. Patient elevated. NIV basics. Delivered via tight-fitting mask, face or nasal. No intubation. Common mode, BiPAP, supports both inspiration and expiration. Function, helps blow off CO2 plus corrects respiratory acidosis. When NIV fails. Intubation. Indications for invasive ventilation. GCS Cli 8, consciousness. Respiratory arrest at silent chest. Aspiration risk or inability to protect airway. Persistent worsening respiratory acidosis despite NIV, admit to ICU for invasive ventilation if needed. Exam scenarios. Scenario 1, 55 m CSOB, widespread wheeze, O2 SAT 85% on room air, BP 120/82, HR 1 and 14, RR 28. Started on 24% Venturi O2. Next step, nebulized salbutamol plus ipratropium. Reason, hypoxia plus dyspnea, bronchodilators are next after controlled O2. Scenario 2, 60 m COPD on 28% Venturi O2, ABG, pH 7.28, rising CO2. Already on nebulizers plus steroids, still dyspneic. Next step, start NIV. Reason, pH 7.35 plus hypercapnia, clear NIV indication. Scenario 3, 67 m COP on NIV for worsening respiratory acidosis. Becomes drowsy, GCS 8, RR 10, silent chest. Next step, intubations, invasive ventilation. Reason, GCS 8 plus poor ventilation. NIV failure, secure airway.